Hello, everyone. Welcome to today's webinar. My name is Chad Severs, and I'll be your webinar moderator today. I want to go over a few housekeeping announcements, and then I'll introduce our speaker and let her do her presentation. So I'm the project manager for Arkansas Building Effective Services for Trauma, or RBEST, and we are a state-funded program at the UAMS Psychiatric Research Institute. And our aim is to improve mental health services for children who have experienced trauma from events such as abuse, natural disasters, or family separation. We work really closely with our state's child advocacy centers and other providers to build a trauma-informed mental health system. We're probably best known for providing training to mental health professionals and treatments that are effective in helping children recover from trauma. So I just want to welcome everyone for joining us. And as always, just a few housekeeping announcements before we get started. We really encourage you all to ask questions. Just use the question feature, which is on the right side of your screen, and we'll address those as they come up or at the very end. And if you're interested in earning a CEU, we will email out a survey, and there's a code at the end of this presentation, and I'll give some more instructions when we get to that point. If you happen to be watching this at a later date on our YouTube channel, we only award CEs for attending live webinars. And so as I just mentioned, we are recording this webinar. We'll upload the presentation to our YouTube channel. And if this topic or other training things that we do are of interest to you, be sure to like us on Facebook or check us out there. That's probably where we most frequently post about upcoming training events. We also have a monthly newsletter that you can subscribe to as well. So I'm going to turn things over to our speaker today, Alyssa Daugherty, and we are really excited to have Alyssa with us. She's completing her postdoctoral fellowship, so she's been hard at work for several months for us, and so I'll just kind of stop talking and turn the webinar over to her and give a warm virtual welcome.
All right, thank you, Chad. Hello, everyone. Welcome to today's webinar. My name is Alyssa. I am a clinical psychology doctoral candidate. So I completed my pre-doctoral internship at UAMS this past June. And as Chad mentioned, I will begin my fellowship officially this upcoming January. So in the meantime, I've been very fortunate to join the RBEST team and really work with amazing staff, trainers, and mentors. I guess regarding TF-CBT, I first learned TF-CBT in 2014 and began implementing this treatment model with children at a children's advocacy center. But I actually just began really working on the requirements to become nationally certified in TF-CBT last year. And we'll hopefully have all this completed sometime next year. So today I'm excited to talk about engaging and strengthening relationships with foster parents in trauma-focused cognitive behavior therapy, or TF-CBT for short. So this information I'm going to present on today will be especially relevant for mental health professionals that are currently using or maybe planning to learn the TF-CBT model, and who work with children in foster care and their foster parents. I know we may have some foster parents joining us today who have participated in TF-CBT or maybe currently or potentially participating in TF-CBT in the future with their foster child. So this information may be validating to hear, or at the very least familiar to you. So I know we have maybe some other people who've joined us, other professionals who work with kids in the foster care system. So hopefully you will find this information equally helpful. So before we dive in, there's just a few caveats I'd like to touch on. So because the focus of this webinar is to discuss engagement of and connections with foster parents in TF-CBT, I won't really have time to go through the actual components and implementation of TF-CBT. So I'm really going to be focusing on the barriers, challenges, and just really unique considerations for working with foster parents. Also, this presentation does not count towards any of the requirements for becoming a certified TF-CBT therapist. But if you are interested in learning TF-CBT and becoming certified, I encourage you to join the RBEST mailing list, as Chad mentioned, or like us on Facebook, and visit the RBEST website to get updates and information about when the next TF-CBT trainings are. So I've included the link here where you can read those requirements for becoming certified. One other thing I want to mention is that sometimes you will hear me talk about foster parents, and sometimes I will specifically mention kinship caregivers. So just keep in mind that while I might be talking about foster parents or using that terminology, it doesn't necessarily mean that I'm excluding kinship caregivers, or those particular points don't pertain to kinship caregivers. So just for sake of not being too wordy, I might just be using foster parents as a term. And so just know that information may be generalizable to both groups of caregivers. So I will briefly touch on some statistics related to foster care and talk about some interesting information about reasons why some choose to become a foster parent, or some reasons why they discontinue to foster. And then I'll talk about some common barriers and ways to address those in treatment. And then I'll go through some considerations when working with foster parents throughout the components of TF-CBT. So the Adoption and Foster Care Analysis and Reporting System collects case level information from state and other federally funded agencies on children in foster care and those who have been adopted with agency involvement. At the national level, preliminary statistics for fiscal year 2018 show that 437,282 children were in foster care. And of these children, about 60% entered the foster care system in 2018. So just kind of a really continuous cycle of this each year. The majority, or 78% of children in foster care, reside either in a relative or a non-relative foster home, so as opposed to a pre-adoptive home or residential facility or other institution. And 32% of these children live with relatives who historically have been primarily a grandparent or grandparents of these children in skipped generation homes or homes where the biological parent does not reside. In Arkansas specifically, there were 4,482 children in foster care in 2018. And although this is still a high number of kids in state custody, this was a 12% decrease from 2017. So at both the national and state level, there's a high percentage of children who stay in care for at least 1 year. And because TF-CBT is an evidence-based treatment for kids ages 3 through 18, at least 55%, or a little over half of children reported to be in foster care were in the age range appropriate for TF-CBT. So of course, age is not the only determining factor for deciding whether TF-CBT is appropriate, but just something to keep in mind. So historically and currently, at both the national and state level, the most common reasons for removing a child from a home, or reasons children are placed in foster care, is because of neglect and parental drug use. So these reasons may not be mutually exclusive, meaning that parental drug use oftentimes results in neglectful environments, but also children are sometimes removed for more than one reason. And children in foster care are considered to be a very high-risk population of youth. Specifically, they have double the amount of trauma exposure and often a history of multiple types of maltreatment compared to the general population. So consequently, these kids are reported to have a multitude of emotional, behavioral, physical health, developmental, and educational difficulties. And research has found that untreated mental health problems and behavioral difficulties have been linked to higher rates of placement disruption and lower rates of reunification and adoption for children in foster care. And this is really important to remember when you begin working with foster parents in a treatment setting, as foster parents are sometimes the primary source of support for these children who may have a lot of needs. So I want to talk a little bit more about foster parents and specifically why they choose to become foster parents and open up their homes to children. So the resource theory is simply the idea that the more resources one has, the more likely they are able to provide to others. So for example, resource factors might be education level, income, marital status, social support, time, and parenting experience. And there's some research suggesting that the more resources a potential foster family has, the more likely they might be to start fostering. So it's not surprising that some other research has concluded that a lack of resources, in addition to maybe parental age, family size, lack of space, might be barriers to fostering children. So other research studies have collected data from current and previous foster parents about their motivations for fostering, most of which are categorized as either child or family-centered reasons. So specifically, foster parents have disclosed reasons for fostering children as just strong desires to provide a safe environment for children, or simply the desire to stay at home and care for both biological and foster children. Other reasons were related to just wanting children in the home or filling an empty nest and increasing their family size with maybe an intent to adopt. Some reasons that are specific to kinship, foster caregivers or family members like grandparents, aunts, uncles, cousins, taking on that primary caregiving role are simply to help another family member out who may not be able to provide care for their child. Research finds that biological parent incarceration, mental illness, neglect, and death are some of the common reasons for grandparents in particular caring for their grandchildren. And depending on the situation, some family members open up their homes just to prevent children from entering the foster care system or being moved to a non-relative foster home. So of course, this list of reasons for becoming a foster parent is not exhaustive, but knowing a foster family's motivation for and even attitudes related to fostering might influence and be beneficial to discuss in treatment. So on the other end, there are a variety of reasons why foster care ends for a child or why foster parents decide to discontinue fostering. So in Arkansas specifically, the most common reasons for foster home closure, even above reasons related to things like permanency, custody, adoption, was due to the foster family request to close their home. And specific details related to the reasons for this were not reported or unknown, but research unspecific to Arkansas finds that many times foster parents discover they're just unable to meet the needs of their foster child. So that could be resource related, like insufficient time, space, or finances, or it could just be some of the behavior or emotional difficulties with the child. Other reasons might be lack of support in caring for the child or changes in personal life circumstances. So this could be foster parent age, health, marital status, that might change their ability to care for kids the way that they may have been able to before. And of course, foster care discontinues for children when they are either reunified with their biological or original caregivers, adopted, or remain or move to relative custody. And something to note that is that Arkansas exceeds the national standard of 40.5% of children achieving permanency or exiting foster care within 12 months of removal. So go Arkansas. So now that I've talked a little bit about who these foster parents are, reasons why they become foster parents or discontinue fostering, I want to transition to talking about foster parents in TF-CBT. So just briefly, for those who may not be familiar with TF-CBT, it is a well-established evidence-based treatment, and it's a good fit for children in foster care, as it is designed to address both trauma-related symptoms and behavior problems. So TF-CBT includes individual sessions with children and non-offending caregivers, and includes conjoint child caregiver sessions, which are typically over a span of 12 to 24 sessions, and focused on various components, which are summarized into the acronym PRACTICE. So caregivers really promote optimal treatment outcomes, and caregiver involvement is extremely important in TF-CBT. And so foster parents are really important to provide education to about the child's trauma, implementing behavior management in the home. And sometimes the treatment might just look different when you're working with foster parents, just because of the circumstances. And based on some research, we know that treatment completion is linked to foster parent involvement. So the principles of TF-CBT that you see on the screen inherently encourage clinicians to consider each child and family situation. So there may be specific adjustments that make sense to consider or implement throughout treatment that are still consistent with these kind of guiding principles of TF-CBT. So next I'm going to talk some about concrete or practical barriers or reasons that make engagement or commitment to treatment more challenging. So foster parents have identified limited appointment times and availability as a barrier to the family's ability to schedule therapy appointments or attend therapy with 100% consistency. And related to this, foster parents sometimes are faced with overwhelming demands. So some foster parents have full-time jobs and care for multiple children with special needs, really making it challenging to juggle possibly several appointments. A lot of foster parents like to attend team meetings and, of course, have just miscellaneous other personal demands outside of caring for their foster child. So many DHS caseworkers strive to provide support to multiple foster families every day, and so this limits their ability to help with or arrange transportation, which is a barrier for some families. So due to some of these challenges, foster parents may express specific preferences regarding where treatment takes place. So for example, foster parents may ask whether treatment can take place at home or at school, alleviating the need to transport the child to the clinic. Some foster parents and even mental health professionals worry about starting treatment without feeling like the current placement is secure. And if you recall, earlier I mentioned that for the majority of children at both the national and state level, the average length of time spent in care is at least a year. So while placement disruption is possible and it may be likely, TF-CBT can be completed between 12 and 20 sessions sometimes, or 3 to 5 months. So therapists can feel more confident about beginning treatment or not letting that fear of placement disruption be a barrier to access. Of course, there are times, though, when it makes sense to wait to begin treatment. For example, if there is a real plan in place for the child to move homes in a few weeks, that might be a good reason to delay treatment. But in general, the concern related to placement stability can be, for one, validated and normalized with foster parents, but also explaining that beginning treatment has also shown to increase the chance that a child might actually stay in their current placement or even increase that placement stability. Okay. So many of the practical or concrete barriers discussed on the previous slide were related to difficulty scheduling or making therapy appointments. I'm going to talk a little now about ways in which those barriers can be addressed preemptively, or ways that might reduce the consistency of that barrier. So first, engagement begins on first contact. So this can be during a phone call. So simply providing reminders of appointments when clinicians are able to incorporate that in their schedule can be really beneficial to foster parents. Even the most organized foster parents can forget sometimes. And in the beginning, therapists can have the opportunity to discuss what might be these concrete barriers to treatment and just problem solve those right off the bat. So, for example, you might consider modifying the way that a foster parent is included in treatment. So while it's ideal to meet with foster parents in person, it is okay to deliver information and provide updates about therapy and even assign homework over the phone or over Skype if foster parents are not able to regularly attend sessions. During the school year, I know late afternoon appointments or sometimes early morning appointments are extremely popular and highly requested from families. So it might be possible to reserve these early morning or late afternoon times only for families that can't make appointments during the school or work day. There are cases or even times when a foster parent and a child's schedules don't overlap well. So if a foster parent is unable to make a therapy appointment, you might consider splitting the therapy appointment so that your 45 or 50-minute session is divided. And of course, if your schedule allows for it and you have agency support, accommodating a family's requested or preferred treatment setting. So if the child or parent is unable to come to you, consider the possibility that you might be able to go to them, whether that's at the child's school or at home. So sometimes it is the case that foster parents are just unable to commit to attending sessions, even including weekly phone calls. So it's important to consider other caregivers that might be able to participate in treatment with the child. So sometimes a caseworker is able to consistently attend sessions, and that would satisfy that need in TF-CBT of having an involved and stable adult for this child. And foster parents can still be made aware of treatment updates, even if that doesn't happen on a consistent basis. Another thing to have accessible or maybe at least allow in the treatment setting, if it's possible, are snacks and drinks. If a family knows that they might be able to provide a snack or a drink to their child before or after session, this could eliminate the need to stop somewhere on their way, or really this just might meet a basic need for possibly both that foster parent and child, who would understandably not be able to fully engage in treatment if they're hungry or thirsty. So you might notice a common theme here, and that is therapist flexibility when it comes to accommodating foster family needs in treatment. So this is something that the developers of TF-CBT strongly support and encourage whenever it's possible. So understanding these practical challenges and needs of a foster family can be addressed at the beginning. And research has shown that even engagement over the phone, as well as kind of discussing some of these treatment logistics at the first visit, really improves treatment attendance and decreases the rate of no-shows. So in addition to practical barriers that a foster family might face, there are also perceptual barriers or certain beliefs, concerns, or expectations about treatment or therapy in general that might interfere with engagement. So something that's not necessarily unique to foster parents, but an idea that exists among many parents, I think, is that their unawareness or maybe their limited understanding of how important their involvement is. So depending on previous experiences with therapy, it's maybe understandable that parents might not expect to meet with their therapist their child's therapist. Of course, foster parents, if they don't know that they're expected to be involved, they might appear as reluctant or wanting to engage in treatment. So unfortunately, some families have had negative experiences with mental health services in the past, or experiences that at least left them feeling hesitant and engaging in services. So I'll talk a little bit about ways to address that on the next slide. On the other hand, some foster parents may not have participated in mental health services, and so they're really unaware of what therapy will be like, even simple things like frequency of appointments. And some foster parents have concerns about how their relationship may look with their therapist. So these concerns might be rooted in therapist age, gender, level of experience, their schedule, maybe cultural values. So just being open to asking about this and discussing with a foster parent really communicates that willingness to work together and transparency, whether that work might continue with you as their therapist or not. It's important to remember too that mental health professionals or therapists sometimes are viewed as being part of the child welfare system, or being part of really important decisions for a child, which can lead to some feelings of hesitancy or maybe distrust in therapists as a provider. So as I mentioned, just as I discussed some ways in which practical barriers can be addressed, I'm going to spend some time now talking about how some of these perceptual barriers can be addressed. So first, emphasize the importance of foster parent involvement in TF-CBT. So communicating this upfront with both foster parents and DHS is really important, and making sure to explain that the foster parent inclusion in treatment is not due to the foster parent being part of the reason for treatment, but because they can be this child's strongest source of support and healing. Similarly, discuss foster parents' expectations of therapy as well as their previous experiences. So we can't rewind time and fix or change those experiences, but we can ask foster parents about their experiences and discuss their concerns and sort of talk about how therapy might look different. If you are a TF-CBT therapist, clarify your role as the family therapist. It's important to discuss the ways in which you might communicate with DHS or others in the child welfare system, but how your job might be different from others that the family might interact with. So foster parents are required to attend and complete certain training before becoming a licensed foster parent. So it's important to provide education about how TF-CBT is maybe different from other training that they might have received, and talking a little bit about what to expect in TF-CBT. Make sure to inform foster parents too that while they might be involved in TF-CBT for their foster child, that the treatment provides support to them as well. So TF-CBT is not individual therapy for foster parents, but provides support in different ways, which can mean processing thoughts and feelings about their foster child's needs in a way that would allow them to continue to support their foster child. But support could also mean working with DHS caseworkers who can provide maybe mileage reimbursement, or for foster parents who may be transporting their child to and from therapy. And therapists can also provide letters to foster parents for attending treatment, and this can serve as continuing education as part of their licensure. Providing psychoeducation to foster parents about what traumatic stress looks like in children can be very helpful in correcting or alleviating concerns related to maybe mislabeled diagnoses. And I think what's important to communicate is that trauma affects children in lots of different ways. So some some ways we can observe and some of which we can't. And sometimes this behavior can really leave foster parents feeling confused and frustrated, helpless. And so as a clinician, you can really normalize these experiences and provide education about trauma. And sometimes kids just have very different reactions to a traumatic separation or removal from their home. And so some kids will find that separation to be relieving or extremely helpful because they are removed from a very negative or abusive environment. And for some kids, this separation is confusing and they don't understand completely why they were removed. And so they might have some mixed feelings about having to rely on this new foster parent. So really just discussing the ways in which that might look for a child and normalizing how a foster parent is kind of perceiving that or feeling about that. So I want to transition now from talking about barriers and how to address those and specific considerations for different aspects of TF-CBT. So assessment is a really important aspect of treatment in general. So traumatic stress symptoms can be monitored throughout treatment. But it's important that foster parents, when they begin caring for a foster child, they receive varying amounts of information related to their child's history. So depending on when a foster family is coming into treatment, it's just important to be thoughtful about the possibility that foster parents may have very limited knowledge of their child's history, as well as the level of functioning or actual traumatic stress symptoms. So in some cases, foster families will come into treatment soon after that child was placed with them. And so they don't have, foster parents maybe don't have a good understanding or good kind of data point yet for how their child is actually doing. So when you can, seek information from other people. This might be DHS caseworkers, or it could be a previous foster parent. And keep in mind that foster parents and children may have very different perspectives and opinions about the child's history. So for example, depending on the age of the child, children may be better reporters of their internalizing symptoms. So experiences that might not be as obvious to foster parents. And sometimes foster parents may believe that certain traumatic events for children were more impactful than they actually were, according to the child. So the event that led to the placement might not be the most traumatizing. And so for a lot of children, the actual separation was the most traumatizing, but not always the case. So there might be differences or discrepancies in reporting or the actual data that you're getting, but it's really important to get both perspectives. They can both be helpful in treatment. So those of you that are familiar with the TF-CBT model, you know that enhancing safety is listed as the last component. But sometimes it is necessary to bump this component to the beginning of treatment. So it's helpful to work with foster parents to figure out what safety means for a child and how the foster parents define safety themselves. So for example, physical safety might be instilled through removing the child from the home. It could be having food. It could be having supervised visitation with their parents. Psychological safety, which sometimes is not considered to be part of safety, but psychological safety or emotional safety might be met for a child by just having a favorite stuffed animal around, or it might be people explaining things that are happening to the child in developmentally appropriate language. Sometimes it's really just giving a hug to a child. So really figuring out what foster parents can do to help children feel safe in their own terms. The enhancing safety component of TF-CBT is sometimes inserted at the beginning of treatment when there are situations that pose real safety risks to either the foster child themselves, the family, or possibly the security of the placement. So these things might be problematic sexual behavior or severe aggression. So coming up with safety plans and helping foster parents with behavior management can be extremely necessary and very beneficial. Foster parents can assist children in reducing overwhelming emotions. So kind of like I mentioned, providing information to them, talking to them about what their concerns are, helping them to communicate, managing trauma triggers, simply listening to a child's needs and really validating their that their feelings are real and that they make sense. And so sometimes the way in which those emotions are expressed are not maladaptive or the way that we want kids to express them. But really validating what children are feeling can provide a sense of safety. A really important thing to remember in TF-CBT is that although foster parents are sometimes the identified caregiver attending sessions, that foster kids a lot of times have visitation with their offending caregivers. So it's important to discuss boundaries with foster parents in regards to if and how they talk about a child's offending caregiver. So it will diminish feelings of safety for a child if they're hearing how much their offending caregiver is not safe or can't be safe. And then this child is later dropped off to visit with that offending caregiver. Something to discuss with a kinship foster parent are issues related to safety due to maybe family relations with the offending caregiver. So this could mean setting firmer boundaries or helping the kinship parent to seek support elsewhere from other people. So moving into the psychoeducation component of TF-CBT, it's important to spend time with foster parents the child's history, especially if there's pieces of the history you know are new information, or if you're not sure if a foster parent is aware of something, and how the children's current symptoms are related to those past and possible maybe recent experiences. So many of the most challenging behaviors are strategies that in the past might have helped that child survive in the presence of abusive caregivers. So for example, lying and stealing might be easily pathologized by caregivers, understandably so, but children may have learned that in a previous home, lying helped them escape really severe physical abuse, or stealing was the only way for them to eat. And so these behaviors still might continue in a foster home, even when those behaviors are not necessary anymore. So it's important to help foster parents establish a trauma lens so that their perceptions don't interfere with their desire or their ability to provide support to the child. Of course, this doesn't mean that every behavior is connected to a child's trauma, but helping foster parents be open to considering whether certain behavior is related to trauma can be tremendously helpful. It's without a doubt that foster children's emotional and behavioral challenges can be very frustrating to foster parents. So foster parents may not understand why their parenting practices that might have been successful with other kids are not working with a certain child. So as a result, they might begin to doubt themselves, question their competence, and even consider maybe not fostering a child anymore. So it can be really therapeutic to simply validate these feelings and just kind of gently provide some knowledge that helps foster parents kind of make sense of their foster child's behavior. And relatedly, just normalizing the difficulties and instilling hope and empowering. Foster parents need to know that they're heard, and as I touched on earlier, many choose to foster because they genuinely care about providing a positive environment for children. So communicating their importance and recognizing their efforts can be really well received. So although parenting is a component of TF-CBT that is revisited throughout the course of treatment, there are a few things that might be particularly beneficial for foster parents. So as a general behavior management rule, helping foster parents to focus on positive parenting techniques like praise, selective attention, reward systems, working with foster parents to identify specific behavior they want to continue, praise immediately after this behavior occurs, strive for consistency, and catch their foster child being good. Sometimes when parents in general are used to responding to unwanted child behaviors, they can sometimes forget to praise their child in the midst of enjoying all the time that they're not having to manage behavior. So discuss behaviors that foster parents can ignore and establish reward systems that are developmentally appropriate, including the foster child as much as possible. So similarly, find behaviors to praise in the foster parent. So just as children like to hear what they're doing well, adults, including parents, find this kind of social feedback very reinforcing. And it's also helpful to hear what you're doing well so that you can keep doing that. So all kids benefit from predictability in their schedule, and this can really help children in foster care with feelings of safety and emotion regulation. So discussing how foster parents can incorporate either daily or weekly routines in their schedule can be helpful. So some foster parents can understandably feel defeated, especially when they feel they have tried numerous approaches to responding to their child's behaviors. So really just encouraging experimentation with new techniques and just expressing foster parents' hard work. Sometimes it's helpful for foster parents to have some additional resources that they can refer to at home. And so the resources listed on this slide are ones that are mentioned in TF-CBT manuals. And so these are not the only resources that you can provide, but these two in particular are really helpful in that the off-road parenting book also has a DVD package. And so there's video vignettes of parents kind of implementing different strategies and kids responding in different ways, and then how parents respond to those different child responses. So sometimes it can just be an additional resource that you send home or encourage foster parents to use outside of session. So I'm going to talk now about how therapists can help support foster parents during the RAC component, or like relaxation, the affect expression and regulation, and cognitive coping components of TF-CBT. So help establish relaxation activities with foster parents. So this is not only beneficial for foster children, but it also facilitates foster parent modeling of skills, and it just helps foster parents' well-being as they're hopefully engaging in pleasurable and relaxing activities. But encourage foster parents to use the coping skills that they're helping their child to learn and practice. They don't necessarily need to use like bubble breathing or belly breathing, but discussing what helps them to relax and what's important for their self-care. So these bowls here really highlight an important analogy and concept, I think, in therapy in general. So the blue bowl really represents the child. It's the smallest and therefore needs a bigger bowl to catch that overflow or when things become hard. So the green bowl represents the foster parent, which is the bowl that is there to encompass the child and catch that overflow. And if you can guess, the red bowl is the therapist bowl, catching that overflow from the foster parent. So really just being a sense of comfort and support in the treatment setting can be very beneficial for a foster parent's well-being. Foster parents might have some inaccurate or unhelpful thoughts related to their foster child. So a couple common thoughts that a foster parent might have is that my love should be enough to erase the effects of everything bad that has happened. Or my child should be grateful and love me as much as, I love her. Or my child shouldn't love or feel loyal to an abusive parent. And so something I really want to emphasize is that when we're introducing cognitive coping for the first time with kids, we may be tempted to immediately correct a child's distortion. But this is the component of TF-CBT that we just want to take note of those distortions that we hear. We don't want to jump to correct those with kids because that can sometimes unintentionally communicate that they're unsafe to disclose some of their thoughts and how they actually see things. But on the other hand, we can address foster parent distortions during the first time cognitive coping is discussed. And this can really, really help with influencing the foster parent perception of and the response to some of the things that they're seeing in their children, and really eliminate some anxiety depending on what kinds of thoughts they're having. Kinship caregivers might need additional support. They might have unique stress related to possibly having to take on responsibilities of a family member's child or children very abruptly. And so sometimes their lives change overnight. And so it's helpful to know and understand the relationship that kinship caregiver has had with the offending caregiver. Because sometimes it's their own child, and it will be beneficial just from additional time spent discussing kind of their feelings and thoughts related to this reality. So sometimes the timing of when to begin trauma narration and processing should be assessed. So in the case that a child might be removed to a different home before trauma narration and processing is supposed to start, it could be helpful to delay starting this stage of TF-CBT until placement does become stable again. Some kids in foster care will have different schedules or different times of the year, such as around holidays or trial home placements that can really affect scheduling. So it's just important to make sure that you don't enter trauma narration and processing phase, knowing that there will be many disruptions in appointments. As you progress through trauma narration and processing, you might learn how certain traumas are organized or perceived according to the child. So it's important to prepare as much as you can with the foster parent, what they will see, what they will hear when their foster child is sharing their trauma narration and processing with them. And during your time spent with foster parents preparing for the sharing of the trauma narration and processing, it's important to mention that sometimes the actual placement with them is part of the child's story that might have some negative thoughts and feelings surrounding that. So foster parents can have very different reactions to this, and it will be important to process with them before having that conjoint session. So the purpose of in vivo mastery is to help a child resolve avoidant behaviors related to traumatic experiences. So in vivo mastery is not always a necessary component of TF-CBT. So if you do decide that in vivo mastery should be included in treatment, it's important to assess or reassess the child's specific trauma triggers and establish that fear hierarchy based on the feared situation. Many children in foster care have complex trauma histories and truly are unable to identify a specific instance of trauma that they fear. So it could be helpful to work with foster parents to help their foster child establish a sense of mastery based on themes from the child's history. And this could mean building trust and support in relationships. So when kids experience what they might perceive to be a lack of support from their foster parent or not feeling like they can trust their foster parent. Foster parents can help provide corrective experiences or allow the child to express their view and work together and establish different measures or ways that that dyad interacts that really provide that sense of mastery for a child. Okay, we made it to the last component of TF-CBT. So although this is the last component I'll talk about today, conjoint sessions can be incorporated throughout treatment as deemed necessary. So as I mentioned earlier, enhancing safety might actually be the last component that is addressed or even like readdressed depending on the needs of the family. So one of the purposes of conjoint sessions is for the child to share their trauma narration and processing with their caregiver. So there are instances where a child is reluctant to share their trauma narration and processing, and sometimes these worries can be discussed and resolved, but there are certain cases when it might not be appropriate for a child to share their trauma narration and processing with their foster parent or their kinship caregiver. So reasons might be foster parent trauma history or mental illness. It could, in some rare cases, maybe not believing the child's trauma history. So really just evaluating the appropriateness of that. And sometimes it's okay to include another adult in the child's life that can be part of that sharing process. So these are just some resources that might be helpful throughout the course of TF-CBT. So the first one is a manual that is specific for foster children in TF-CBT. There's also a few books listed here that might be really helpful to use with kids, and foster parents can even purchase these and use them at home. And the last thing listed here is the National Child Traumatic Stress Network. It has tons of resources for both therapists as well as foster parents. And so always go to that website. It has great information. There's just tons of resources out there. If anyone has resources that they've used in the past with foster parents or families, feel free to type them in the questions box. We can share those after the webinar. So before I answer any questions, I just want to give a warm and fuzzy shout out to all previous, current, and future foster parents and kinship caregivers. You make a difference in children's lives, and on behalf of all children, thank you for doing what you do and providing love and support to children during what might be the most difficult time of their life. And I also want to recognize all the mental health professionals who work with foster and kinship families. Your commitment to supporting families and helping children is incredibly impactful and highly valued. And lastly, November is National Adoption Month, which was something that started in 1976 to raise awareness about the need for adoption. So thank you to all past, current, and future adoptive parents and providing a permanent home and family for children who need it. I guess we can answer any questions at this point, if anyone has them.
All right, thank you for that. So type in those questions and we'll get to the CEU slide here shortly. So one question that I thought I would ask, and maybe your folks are about to type in, is just tips or tricks on kind of initial communication with foster parent and caseworker, like kind of lessons learned or words of advice or wisdom that you might have for that.
Yeah, so I know sometimes it can be difficult because caseworkers are trying to meet the needs of multiple families and multiple children. Sometimes it can just be a lot of phone calls made or phone tag that's happening. Should I get in touch with either the caseworker or the foster parent? So try different methods. You know, if you have emails, try kind of every other day. It just takes a lot of commitment, I think, to doing that. But just trying different avenues, sometimes just contacting maybe a different caseworker or supervisor can be helpful in kind of making that initial contact. I know I've kind of come across issues too where sometimes you don't have the right contact information for families or even the caseworker. So just kind of trying different avenues, different people that might be able to get you in contact with who you need to.
All right, great. I think that's a really great point too, just multiple avenues. Let me just kind of speak a little bit to the CEU. The code for today's webinar is 2011. Shortly after we end this webinar, I will email out a survey that you'll be asked to enter that code, so please jot it down. The code is 2011. If you happen to be watching this with a group, the survey will go to whoever is signed into the webinar, and feel free to distribute that to those who watch as a group. So, okay, and there's a couple of resources that are coming in, so we'll be sure to share those as well. And one thing I really appreciated about your presentation, Alyssa, is all the nice citations and resources. And we've gotten lots of questions. Can we make this presentation available for folks to download? So we can definitely make that happen, and I'll share that with the group after presentation. So any other questions that folks have or thoughts about today's webinar? Well, I will leave. If questions come to you after, you'll have my email, and I'll be happy to pass those along. I just wanted to thank Alyssa for her time and energy in doing this webinar and presenting on this important topic.
Yeah, and thank you everyone for joining us today.
Okay. All right, so I'll leave the slide up here for a little bit, but we'll hang up the audio. So have a good day, everyone.